Good afternoon. Today I'm going to talk about iron deficiency anemia in children. So now let's see what is anemia. So anemia is reduced oxygen carrying capacity of the blood. So because of that reduction can be either reduction in the number of RBCs and also in the size of RBCs. Finally, it leads to reduced oxygen transport and leads to complications. So now we can see what is the normal hemoglobin level. In children between 6 months to 5 years of age, the hemoglobin should be more than or equal to 11 gram per deciliter. And in children between 5 to 11 years, hemoglobin should be more than or equal to 11.5 gram per deciliter. And in children between 12 to 14 years of age, it should be above 12 gram per deciliter. So, what is the prevalence of anemia in children less than 5 years of age? Throughout the world, according to 1990 census, the prevalence was around 51%, whereas in 2011, it reduced to 43%, but it has to reduce more. In India, according to 1990 census, the prevalence was 75% compared to 61% in 2011. So, in Indian states, we have a National Family Health Survey report, which is conducted once in every 10 years. The third survey was done in 2005 to 2006, and the latest survey was done in 2015 to 2016. So, this NFHS gives a valid information on health statistics. So, what does latest NFHS survey say about the prevalence of anemia and nutritional indices? So, we have taken a few states to compare the results or prevalence. Children less than 6 months of age who are exclusively breastfed. In Haryana, it is about 50.3%, with Andhra Pradesh being the highest percentage showing exclusive breastfeeding. And children between ages 6 to 8 months of age receiving solid or semi-solid food and breast milk, the percentage is higher in Tamil Nadu of 67%. Children aged 6 to 23 months receiving an adequate diet, the percentage is still higher in Tamil Nadu with 31%. Similarly, children between 6 months to 5 years of age who are anemic with hemoglobin less than 11 gram per deciliter, the prevalence is higher in Haryana with 71.7%. And non-pregnant women, that is women between 15 to 49 years of age of reproductive age group who are anemic with the hemoglobin less than 12 gram per deciliter in percentage, it is also higher in Haryana with 63% prevalence. So now we will see what is the pathogenesis behind iron anemia. So because of anemia, because of some nutritional deficiency or any pathogenic cause, there is impaired formation of RBC. And that can be due to either the formation of RBC is in defect, or the normally formed RBC is destroyed in excess, or there is acute or chronic blood loss. Now we will see what happens, what is the reason for each. So the impaired formation of RBC can be due to nutritional deficiency. The common nutrients which can lead to deficiency or anemia are iron, vitamin B12 and folic acid deficiency, of which iron deficiency is more rampant in our country. And sometimes the formation can be due to marrow failure, bone marrow failure. That can be due to aplastic anemia or any myelodysplasias, or the bone marrow being replaced by abnormal cells, as in leukemia or storage disorders. Or presence of toxins can also impair the formation of RBC, the main cause being lead toxicity. And the increased destruction. Next category is the normally formed RBC being destroyed in large number. So what could be the reason? One is hemolysis. That hemolysis can be secondary to autoimmune hemolytic anemia and sickle cell disease. Hypersplenism, which can lead to sequestration of RBCs and destruction. And also infections like malaria can lead to hemolysis. And finally, the blood loss also can lead to anemia. That loss can be acute loss or chronic loss. So, as said earlier, iron deficiency anemia is the most common cause of anemia in our country. Now, we will see what happens in iron deficiency anemia. So, before anemia manifests clinically, there are certain stages after which anemia occurs. So, this picture shows this is a normal storage iron. This is the RBC iron which is present inside the RBCs. The storage iron, most common form is ferrit. And there is a homeostasis between the storage ion and the RBC ion. So whenever there is a decrease in the RBC ion, the storage ion will come for help. And the transport ion plays a mediator role. This is a normal state. When there is iron depletion, either due to reduced intake of iron or iron-rich substances, there is a depletion in the storage ion. So this state is called iron depletion state. However, the RBC ion remains normal. Only the storage part is affected. When at this period, iron supplementation is not being done or proper diagnosis is not being done, this progresses to iron deficient state where the storage ion is completely exhausted and the RBC ion also starts to decline. Eventually, when there is no supplementation or intervention, it leads to iron deficiency anemia, where there is complete loss of storage iron and also RBC iron is also almost lost. So at this stage, there will be clinical manifestation and all the clinical features of iron deficiency anemia will manifest. Iron deficiency. So as said earlier, the depressed levels of total body iron, that is storage iron, with preservation of levels of erythroid iron, that is RBC iron. Whereas iron deficiency anemia, all are deficient and clinical manifestations of anemia have come. Okay. Now we will see what is the homeostasis of iron. So, normally the dietary iron, whatever we take, gets absorbed from the duodenum. So, at an average rate of 1 to 2 milligram per day. Since this dietary iron then goes into the plasma where the transferrin is the transport protein. Approximately 3 milligram of body iron is present in the transferrin and it gets transported to bone marrow for RBC production and also to the muscle to get stored as myoglobin, which accounts for 300 milligram of iron. Bone marrow iron also contributes about 300 milligram of total body iron. In the bone marrow, the iron is used for the production of RBC precursors and mature RBCs. And the RBCs eventually, when get destroyed in the reticuloendothelial cells, the iron gets trapped in the reticuloendothelial cells, where the storage form contributes about 600 milligram. And also, major storage organ for iron is liver, where 1000 mg of iron is getting stored. And there occurs a homeostasis between all the organs. So whenever there is a depletion of iron, the storage iron comes into help and increases the plasma or erythroid iron. Okay. Hope everyone follows. So the net balance is 0. Now we will see what is the cellular mechanism of absorption of iron. So there are two different forms of iron, ferrous and ferric form, whereas the ferrous form gets absorbed easier. Even if ferric form iron is present, it should get converted into ferrous form by ferric reductase enzyme so that the ferrous form gets easily absorbed into the enterocyte. So the ferrous enters into the enterocyte. It can either be stored as the storage iron ferritin and or when there is a demand in the blood, it goes into the blood compartment through the ferroportin transporter. So in the blood, the factor that can affect absorption of iron is a component called hepcidin. Hepcidin plays a major role in iron absorption and iron regulation in the body. So, the iron gets incorporated into the RBCs, or when there is no demand in the body, it gets stored in the storage cells like major myoglobin in the muscle, liver, and macrophages of the reticuloendothelial system. Now we will see what is hepcidin. Hepcidin is a 25 amino acid protein which is an active form, and it plays a major role in iron absorption. It gets excreted by the kidneys. Okay. So what is hepcidin and when it is secreted more or when it is down-regulated? So whenever the body is in a iron depleted state, the hepcidin level reduces. For example, when the depleted state, major example is anemia, or when there is a due to genetic factors, when there is ineffective or expanded erythropoiesis stimulating agents, when these are being given, the body is in a need for iron. At that time, hepcidin secretion will be downregulated. This minus sign indicates downregulation. So when in the absence of hepcidin, whatever iron being taken orally or by through diet by the patient will get absorbed in the body. On the other side, when the body is in excess of iron, as in when the body is in oral iron administration, repeated RBC transfusions, or genetic factors, and infections or inflammatory diseases, this you have to remember, infections or chronic inflammatory diseases, hepcidin secretion will be high, will be upregulated. So when the hepcidin secretion is high, the iron absorption will be low. Okay. So these are the reasons. So these are the down regulators of hepcidin secretion. These are the up regulators or promoters of hepcidin secretion. So this explains this increased hepcidin secretion in infectious or inflammatory diseases explains the anemia of chronic disease or anemia of chronic inflammation. So what is the role of hepcidin in anemia? So classical iron deficiency anemia, iron deficiency and also iron deficiency anemia, hepcidin is suppressed because the body is in need of iron. So if hepcidin is suppressed only, the whatever iron being taken can be absorbed in the body. So it is suppressed below the limit of reduction in biological fluids. So what is the role of hepcidin in iron deficiency anemia? So in iron supplementation in iron sufficient states, serious adverse outcomes can happen. So when there is an iron sufficient state, the hepcidin becomes upregulated so that excess iron will not get absorbed in the body so that the serious adverse outcomes can be stopped. As I said earlier, in inflammatory disorders, anemia of chronic disease and iron deficiency anemia, concomitant iron deficiency lower hepcidin levels as compared with pure anemia of chronic disease. So in anemia of chronic disease, because of the chronic inflammation, hepcidin secretion is if hepcidin secretion is increased, so that and consequently it reduces iron absorption and leads to anemia of chronic disease. What are the effects of iron deficiency anemia? So first of all, per se anemia, mostly it remains asymptomatic. When it becomes symptomatic, the common symptoms are lethargy, tiredness, fatigability, tachycardia, irritability, poor appetite. Eventually, when the anemia is severe, it may also lead to congestive cardiac failure. What are the new and also iron deficiency anemia also have some neurocognitive effects. It affects the psychomotor and mental development in children, growing children, and a reduction in breath holding spells is noted on iron supplementation, which shows that iron deficiency has a role in the pathogenesis of breath holding spells, and it can also present like restless leg syndrome, periodic limb movement disorders. It may also lead to pica. What is pica? Compulsive consumption of non-nutritive substances for at least 1 month. Geophagia, eating of mud. Amylophagia means excess eating of starch. Pagophagia means excess eating of ice. Increased lead exposure with side effect. Consequences of pica are because of this there is a increased exposure to lead which may lead to side effects. Immunity. So impaired lymphocyte function leading to defective interleukin 2 and interleukin 6 protection. So children who are chronically deficient in iron can have low immunity, which may manifest as recurrent infections. And in iron deficiency anemia, there is a compensatory thrombocytosis. There is a 10 times increased risk of stroke. This should be kept in mind, this thrombocytosis. Epithelial changes like angular stomatitis, glossitis, platinikia can also manifest. Other manifestations are impaired sexual and reproductive development. This is more important in adolescent anemia, hyperactivity syndrome, ADHD. So, what are the neurological manifestations of iron deficiency anemia? So, levels of hemoglobin seem to correlate to cognitive performance, but iron supplementation improves cognitive function regardless of the hemoglobin levels. High risk of long-term impairment in mental and motor development been noted. Mitochondrial damage and altered dopamine serotonin metabolism can also happen. All this leads to neurodevelopmental abnormalities of chronic iron deficiency anemia. So this article shows the developmental profile in children with iron deficiency anemia and its change after therapeutic iron supplementation. So it concludes that children with iron deficiency anemia have suboptimal developmental scores compared to children who are not anemic. The delayed development is variably reversible following oral iron therapy. So the reversible it varies depending upon the pre-treatment hemoglobin level and also age of the child. So a hemoglobin level of less than 7 gram per deciliter and age more than 2 years of age when the treatment is started predict a suboptimal outcome in the developmental scores. So this shows the importance of yearly identification and treatment of iron deficiency anemia with iron or transfusion. So now let us see what is pica. Unusual craving for and ingestion of either edible or inedible substances over a period of at least 1 month, inappropriate to the developmental level of the child. And it is also not culturally supported. The commonly taken non-nutritive substances are mud, starch, and ice. Sometimes hair also can be taken by the children. So it is commonly seen in nutritional deficiencies like iron, zinc, calcium, and developmental disorders like autism spectrum disorder, obsessive compulsive disorder, and psychiatric illness like schizophrenic disorders. So treatment for pica include combined behavioral, social, and medical approaches along with treatment of iron deficiency anemia if present. So what are the effects of iron deficiency? Because of non-availability of iron, there is an unavailability of iron or iron which is present not utilized properly, or even blood loss also can lead to anemia. So what are the reasons for unavailability of iron? The most common cause is reduced dietary intake. So insufficient intake, or the intake is good but the body's demand is high, as in when the growth is happening in a higher range, as in infancy and also in adolescence where there occurs a growth spurt, the body demand for iron is high. So at that time, the sufficient intake should be taken. Otherwise, it leads to unavailability of iron. Or the diet is good enough, but the body is not able to absorb the iron, as seen in celiac disease, H. pylori infection, etc. So let us assume the availability is good, but the body is not utilizing properly. What is the reason? As said earlier, in anemia of chronic disease, hepcidin levels are high. That leads to reduced absorption of dietary iron, and leads to anemia of chronic disease. So this is commonly seen in chronic kidney disease, chronic rheumatological illnesses. And also drugs like glucocorticoids also yeah, affect the utilization of body iron. And blood loss, either acute or chronic blood loss like GA bleed, parasitic infections also leads to iron deficiency. So now we have seen what is the prevalence of iron deficiency anemia and what are the clinical manifestations of iron deficiency anemia and what are the reasons, what is the pathogenesis and causes for iron deficiency. Now we have to diagnose iron deficiency anemia. So do we need any costly or expensive investigations? No. Only a simple hemoglobin estimation shows the presence of anemia, and also to determine the cause, we can go for some certain few more investigations. Like we can do a complete blood count, which shows a complete hemogram, which shows a decreased mean corpuscular volume and MCH. So that is the characteristics of iron deficiency anemia. That is microcytic and hypochromic cells. Both size reduction in the size of the RBCs and reduction in the hemoglobin content. So leads to the color chrome of the RBCs is reduced. And there is a increased red cell distribution with. So apart from complete hemogram, we can go for a peripheral smear, which can identify the microcytic hypochromic RBCs. So this smear shows the presence of smaller sized RBCs compared to the normal size RBCs, and also you can see there is a increased central pallor compared to a normal. Here, this is a normal RBC. Compare this one and this, there is an increased central pallor because of reduction in the erythroid iron. So there is these are the characteristic features of peripheral smear in iron deficiency anemia. Small RBC compared to lymphocytes, and also central zone of pallor is increased, and abnormal shaped cells due to anisopoikilocytosis. Variable size of the RBCs because of anisopoikilocytosis. That is different stages of different cell formation and maturation. Okay. Next, if needed, we can go for a fewer investigations which can confirm, which can show the body's iron status. As said earlier, there are two forms of iron. One is erythroid iron present inside the RBCs and blood compartment. The other is the storage iron, stored mostly in the muscle as myoglobin and also in the liver and reticuloendothelial cells. So this serum ferritin is a measure of the storage iron. Uh, we can do serum ferritin to see the body iron stores, and also we can check reticulocyte hemoglobin content or equivalent. What is serum ferritin? It is a very sensitive indicator of a body iron. But what is the disadvantage with the serum ferritin is that it is an acute phase reactant. So if the body is having any acute infection or acute inflammation due to any reason, the even in the presence of reduced ferritin, at the time of testing, it can lead to false positive test, as it may show false positive high values. We may assume that the storage iron as ferritin is normal. But since it is, we have to keep in mind that ferritin is an acute phase reactant, so it can be increased in an inflammatory condition or acute infectious conditions. So that is the major disadvantages of serum ferritin measurement to diagnose iron deficiency anemia. So the cutoff value for adult male is 20 to 250 microgram per ml of blood of serum ferritin. In female, 15 to 150 microgram. So it is a better indicator. So if you are going to check serum ferritin level to measure body iron stores, you can also do combine the testing along with CRP to see if there is any acute inflammation, which may be reflected as elevated CRP levels. And we can check reticulocyte hemoglobin concentration. These are advanced testing, newer testing. But if you are, these may not be needed routinely in all children. This is done by flow cytometry. It is the strongest predictor of iron deficiency. Another parameter, newer parameter that is being checked recently is immature reticulocyte fraction. What is immature reticulocyte fraction? It helps in evaluating marrow Marrow erythropoietic response to anemia in patient receiving erythropoietin or iron therapy. So, if you want to see the response of oral iron or iron therapy to iron deficiency anemia, you can check immature reticulocyte fraction. It is the earliest marker of marrow response. It increases even before retic count and hemoglobin concentration, hematocrit and RBC count. So this parameter can be used to assess response to treatment in patients being treated with iron. Okay. And also, if you are not able to do these investigations, we can do a clinical diagnosis of iron deficiency anemia. Presence of clinical pallor and the presence of a proper diet history showing diet deficient in anemia, deficient in dietary iron, and also if we see an increase in hemoglobin of 1 gram per deciliter after 1 month of starting oral iron therapy, that itself gives a retrospective diagnosis of iron deficiency anemia without any investigations. So, to start treatment with oral iron, the dose should be adequate, the absorption of iron in the body should be good, and the complaints of the patient to treatment should be good. If suppose we are not, if suppose the patient is not satisfying any of these parameters, and also if there is a presence of icterus and splenomegaly along with anemia which is not hypochromic or microcytic, which is characteristics of iron deficiency, and also presence of reticulocytosis or presence of pancytopenia, these are the red flag signs, and we have to think about other etiology than iron deficiency anemia and proceed further. So presence of, I repeat again, presence of icterus, splenomegaly, and anemia, which is not hypochromic or microcytic on peripheral smear, or presence of reticulocytosis or pancytopenia, we have to think about other causes for the anemia and do workup accordingly. Now we will see what are the differential diagnosis of microcytic anemia. So one is the major differential diagnosis is thalassemia. The other one is anemia of chronic disease. Let's see how the complete hemoglobin parameters and ferritin levels in each condition. In iron deficiency anemia, as we have seen earlier, MCV, that is the cells are smaller in size, mean corpuscular volume. So definitely it is decreased. In thalassemia also it is decreased, whereas in anemia of chronic disease, it can be either normal or decreased. Whereas red cell distribution width, it can be increased in iron deficiency anemia. It is characteristics of the increased RDW is a characteristic feature of iron deficiency anemia, whereas it is normal in thalassemia and also normal. It can be normal in anemia of chronic disease. Serum ferritin levels. So as we have seen earlier, serum ferritin or the storage form of iron is definitely decreased in iron deficiency anemia, whereas it is normal or increased in thalassemia, and also it is very much increased in anemia of chronic disease. Now we have seen what is anemia, what are the common causes for anemia. Among that, we are dealing with iron deficiency anemia, which is the commonest nutritional cause for anemia in our country. What is the prevalence? What is the pathogenesis? And what are the clinical features of iron deficiency anemia? And how to diagnose iron deficiency anemia? Now we are going to see how are we going to treat anemia. So there are three components of treatment. One is iron therapy, the other is dietary changes, and we have to see the monitoring, and also we have to see for what is the response to the above two interventions. These three should go hand in hand. We should not only start iron therapy and just leave. We should follow up the patient adequately. Now we will see iron therapy. So, oral iron. The dose for oral iron is 3 to 6 mg per kg per day of elemental iron with a maximum of 150 mg per day. These are the precautions that should be taken. Oral iron should be taken in between meals because presence of food decreases the absorption of iron, and vitamin C rich diet like citrus fruits will increase the or enhance the absorption of iron. Iron is present in different formulations like bivalent, trivalent, and various combinations. What is a common side effect of oral iron? It can lead to constipation and diarrhea, but these are very uncommon. Sometimes staining of teeth can happen, but that is only temporary. It can be reduced by regular brushing and rinsing the mouth with water after taking oral iron. So these are the different formulations of iron that is available. So bivalent formulations is ferrous form. Trivalent means ferric form. As we have seen earlier, this ferrous form is the absorbable form of iron. If ferric form, it should get converted into ferrous form and then only it gets absorbed. So the drugs which are available are ferrous sulfate, ferrous fumarate, ferrous gluconate, succinate, glutamate, and lactate, and prolonged release formulations of ferrous sulfate. Trivalent forms available are ferric ammonium citrate. Absorption. As said earlier, it need not get any conversion for absorption, but it should get converted to ferrous form. Cost. It is cheaper. Little costlier preparations. Bioavailability is good. However, it can be impaired by dietary phytates, tannic acid, etc. The bioavailability is 3 to 4 times lesser than ferrous form, so need higher doses should be given in the ferric formulations. Common side effects, GI side effect. Similar profile is seen in ferric forms also. Special information, ferrous sulfate, it has a salty astringent taste, non-palatable, sorbitol in syrup formulation because of poor stability. Whereas here it is extremely poor solubility of ferric iron in alkaline environment. Toxicity. Because it is present in an easily absorbable form, the toxicity potential is more with bivalent or ferrous formulation. So acute poisoning potential is high if taken in large doses. Since it requires conversion to ferric form, there is a lower poisoning potential compared to bivalent forms. Okay. Now we have seen iron. Now these are the combination iron formulations. That is iron along with amino acids, iron along with polymaltose complex. So type of drugs, conjugates of ferrous or ferric iron with amino acids such as glycinate, ferrous bisglycinate, ferric triglycinate, and ferrous glycine sulfate. These are the amino acid combinations. Iron polymaltose combinations, non-ionic iron with polymaltose, that is carbohydrate. The absorption is good. Absorption is not affected by, the major advantage of this combination is the absorption of iron is not affected by the presence of food. And these preparations are a bit costlier compared to bivalent or trivalent forms. Bioavailability, even it is very good in presence of dietary inhibitors. Side effects profile is lesser. Side effect profile is less than ferrous sulfate. It doesn't have any specific color or taste of food product. No pro-oxidant properties. Environmentally, it is relatively stable medicine. And doesn't stain tooth also. This iron polymaltose complex. Toxicity less likely or low compared with bivalent forms. These are the other combinations. Carbonyl iron, heme-based preparations. That is, iron is present as heme only. So type of drugs, highly purified metallic iron. It is a heme form of iron. Absorption is slow and it is sustained release formulations are present. Absorption is good as present as a heme iron. Both are costlier and bioavailability is high even in the presence of food. Side effect profile, less side effect profile, and lesser toxic potential is seen. So which preparation to give? Almost all preparations are equally effective. Timing of response may vary. Iron amino acid chelates have more advantage. Carbonyl iron not being extensively used in children. However, remember, in government supplies and national programs, this bivalent iron as ferrous sulfate is a standard used as a standard treatment because of its acceptability, low cost, high effectiveness, and tolerability level. Now we are going to dietary change, parenteral iron therapy. So when there is a, what are the indications for parenteral iron therapy? It is indicated in malabsorption, GI intolerance, and non-compliance to treatment of oral iron. So the dose is the hemoglobin deficit into 2.145 into weight in kg. This dose is given as The commonly available parenteral iron formulations are iron sucrose, low molecular weight iron dextran, ferrigluconate, ferricarboxy maltose. Side effect is anaphylaxis, and we need not give any test dose for before parenteral iron therapy. Dietary changes. So certain dietary advice should be given when in iron deficiency anemia. So if a child is bottle fed, so getting rid of bottle feeding, undiluted cow's milk should not be used before 1 year of age. If failure of lactation, if any formula feeds or supplementary feeds given, that should be treated along with iron, oral iron. Restricting daily intake of cow's milk less than 500 ml per day for children more than 1 year of age. Iron consumption of iron-rich food. So the green leafy vegetables, nuts, dates, non-vegetarian foods, organ meat, especially liver meat, those are very rich sources of iron. Iron and usage of iron pot for cooking, and no simultaneous calcium supplement should be given along with iron therapy. So apart from iron therapy dietary changes, we have to see, as said earlier, we have to follow up to see the response to iron therapy and dietary changes. So we have to repeat a CBC after 1 month to expect a rise of 1 gram per deciliter after 1 month in hemoglobin. And also we have to repeat after, if the response is good, we have to repeat after 2 to 3 months to confirm normalization of the levels of hemoglobin, and continuation of supplementation for further 3 months to improve the storage form of iron. Okay, what are the AAP recommendations for anemia prevention in infants? In preterm infants who are fed on human milk, 2 mg per kg per day of prophylactic iron should be started from 1 month of age and should be given till 12 months of age. If the baby is a term baby and term baby but low birth weight, or infant born to diabetic mother, and if a breastfed baby, iron supplementation should be started from 4 months of age with 1 mg per kg per day dose till iron containing complementary feeds are started around 6 months of age, around 6 to 8 months of age. So this is the AAP recommendation for anemia prevention. So now we have seen what is the treatment of anemia, iron deficiency anemia. Now we are seeing what are the nutritional programs or programs related to prevention of anemia in India, that are operational in India. The first country to start nutritional anemia prophylaxis program is India. It was started in 1970. Inclusion of anemia prevention was taken under National Nutritional Policy in 1993. And also the newer scheme is Iron Plus Initiative, started in 2013. Both prophylaxis and treatment regimen are included in the National Iron Plus Initiative. Here, iron supplementation is given depending on the various age groups provided by ASHA and also by school teachers. And there is a newer modified version of Iron Plus Initiative, that is that will be Anemia Mukt Bharat. We will see about that later. So these are the formulations available under National Nutritional Anemia Prevention Program. That is iron and folic acid syrup containing ferrous sulfate, bivalent iron and folic acid. The syrup contains 1 ml 20 mg of elemental iron, and comes as a 100 ml pack. And also tablets for older children, iron and folic acid tablet. 1 tablet contains 20 mg of elemental iron. And there is a iron folic acid drops. The drop contains 1 ml of 25 mg of elemental iron. So, how to prevent? Apart from iron prophylaxis, deworming, regular deworming is recommended in children. So, to prevent anemia due to chronic blood loss due to parasitic infestations. So for age group between 1 to 2 years, for 200 mg, that is half tablet of the 400 mg tablet being given. Above 2 years, 1 400 mg tablet is given for anti-helminthic therapy. So now let's see about Anemia Mukt Bharat. What is Anemia Mukt Bharat? It is an updated version of National Iron Plus Initiative campaign. It has 6x6x6 strategy. That is, there are 6 sets of beneficiaries with the 6 sets of goals and 6 sets of institutional mechanisms. It is a national policy. Let's see who are the beneficiaries under Anemia Mukt Bharat. There are 6 set of beneficiaries. One is between 6 months to 59 months of age. That is 6 months to 5 years of age. From 5 to 10 years of age, 10 to 15 years of age, pregnant mothers, lactating mothers, and women of reproductive age group between 15 to 49 years. So, under Anemia Mukt Bharat, each age set of beneficiaries receive iron and folic acid, and the frequency depends upon the age group, and also regular deworming being done in children. Between ages 6 months to 59 months of age, the dose of iron and folic acid is 20 milligram elemental iron. Remember, this is elemental iron and 100 microgram of folic acid. This is given bi-weekly, that is 2 times a week, along with deworming once in every 6 months from 1 year of age. So no deworming below 1 year. It starts from above from 1 year of age. For age group between 5 to 10 years, the dose is 45 mg elemental iron and 400 microgram of folic acid. That comes as a pink tablet. It is given weekly. And biannual deworming with albendazole being given. For 10 to 15 years of age, 60 milligram elemental iron and 500 microgram, that comes as a blue tablet. It is also given weekly with biannual deworming. For pregnant mothers, it has to be taken daily. The dosage is 60 milligram elemental iron, 500 microgram of folic acid. It comes as a red tablet. 180 tablets are given to the mother, and it should be started from 14 weeks of gestation, continued till delivery, and it should be taken daily by the mother. For lactating mothers, the same dose, same red tablet, and should be taken daily from the day of delivery till 6 months postnatal period. And women of reproductive age, that age groups is between 15 to 49 years of age, they should be given the same 60 mg and 500 microgram folic acid red tablet, but the frequency is weekly. Once in a week should be given. So what are the 6? We have seen who are the beneficiaries of Anemia Mukt Bharat. These 6 interventions are done under Anemia Mukt Bharat. As we have seen earlier, prophylactic iron folic supplementation for 6 set of beneficiaries, regular deworming being done. Apart from that, to prevent anemia from the infancy, intensified year-round behavioral changes should be practiced and emphasized, including delayed cord clamping that may delay or prevent the early onset of anemia in children, in infants, and testing of anemia using digital methods, provision of iron and folic acid fortified foods through governmental policies, and addressing non-nutritional anemia in endemic pockets with focus on malaria, hemoglobinopathy, and fluorosis. Okay. So, what are the issues? We have so many policies right from 1970, but why we are not able to achieve anemia-free country? Because because of the perinatal risk factors. These are the issues that that causes a increased prevalence till now. Perinatal risk factors like poor iron reserves in mother, timing of umbilical cord clamping, dietary factors, lack of dietary knowledge, or diet poor in iron, bottle feeding, excessive cow's milk feeding, or GI diseases like giardiasis, celiac disease, or increased blood loss like parasitic infestations, programmatic and organizational issues. These are the issues that causes a still highly prevalent iron deficiency anemia in our country. Okay. Daily versus intermittent dosing. Since hepcidin is upregulated in its iron flourished state or iron excess state, intermittent dosing also helps in or enhances iron absorption. Okay. What is the take-home message? As we have seen, among the nutritional causes of anemia is highly prevalent in our country. The most important cause for anemia is nutritional anemia. Among nutritional anemia, iron deficiency anemia is the most common cause of anemia. So, adequate implementation of governmental programs helps in reduction in the incidence and prevalence of iron deficiency anemia, and fortification of food should be done. And as pediatrician, we have to diagnose yearly, and with simple hemoglobin estimation that will be fine, and adequate treatment and adequate duration of treatment should be given to prevent the long-term neurodevelopmental abnormalities associated with iron deficiency anemia. We have to take a oath. So let us stop anemia, and with this, I will finish my lecture. Thank you.